Hey y'all. So we're gonna give a couple people a few minutes and then we'll get started.
What page do you have, Carla?
84. Page 84.
84.
Yeah, what's up, girl?
Wait, is she at home?
Yes, there we
Where's her
go.
brother? She's on mute or something.
Can you hear me?
Now we
There
can.
go.
Yeah.
Okay, now I'm muting my phone and walking away from it.
Okay.
Sorry, guys, I have important business to take care of.
You made good time.
So wait on Emily.
Emily, and then
April.
Kaylee and April.
I touched April. So. And I sent out the Zoom link. Hey Hannah, can you say hi? Hannah. There we go. Hi.
Hi.
Okay. We're just waiting on a couple people. I don't know if Emily's gonna show up today. So this will be pretty quick though. We're gonna start with as soon as Kaylee gets back from the restaurant, we'll go ahead and start. I don't know. I'm not certain where April is. So. If you have your books, if you're gonna highlight or whatever, it starts on page 84. We're gonna do what we usually do. There's not a lot of complicated stuff in this chapter, so that's nice. We'll just talk through each header. You guys can ask questions. I'll give you examples of real life practice, kind of things to highlight what it looks like, and then that'll be it. This should not take much more than an hour, if that long. So this is a pretty, this is pretty easy content. At least that's the impression I got from it. We're gonna go ahead and start. I can't wait. So chapter 8 talks about post-processing. It's pretty straightforward with that. It's basically we get our information, we do our scan, and then everything we do after that is kind of classified as post-processing. So we'll start with the retro recons or so yeah, we'll start with retrospective recons. Basically, in practice, what that means, what that looks like is, say we scan an abdomen, right? And we're like, oh, you know, I look at the pancreas, and I'm like, man, I want to see that a little more sharply and with greater, spatial resolution in the longitudinal direction, meaning I want to see the pancreas better with thin slices and more detail. What I'm going to do is I'm going to take that scan, I'm going to add a reconstruction to that, okay? And the reconstruction is going to utilize raw data and let me change some things. So I'm going to use the same field of view, but I'm going to, instead of doing 5mm slices in the abdomen, I'm going to do 2 or 3mm slices through the section of the pancreas only. And instead of using the medium smooth kernel algorithm filter, whatever you want to call it, on my reconstruction, then I'm going to use a little more of a sharp filter on there. And then when I reconstruct that, then I have these kind of really sharp, really thin, crisp pictures of the pancreas that'll help me to identify pancreatic masses because they can be small. So sometimes that happens, right? And that's a retrospective recon. It's after I've scanned, I went back and reconstructed my images. Another thing they can do, say we scan an abdomen, again, 5mm slices, but now they saw something wrong with the lumbar spine on the abdominal scan. So we can go back in, we can decrease our display field of view to improve the resolution of that specific region. So we come in like to the SI joints laterally and then down from the diaphragm to midway through T12, right? And then we cut it off at the bottom, like halfway through the sacrum. So we've got this small box now for our display field of view, and we're gonna change some things again. Again, we're gonna change our slice thickness from 5mm down to 3mm, and instead of reconstructing an abdomen filter, we're going to use a bony filter so that it's really sharp and we get that bony detail. Now remember that we're doing this without exposing them to greater dose. And we're changing quite a bit, so much so that that scan looks like it was scanned as a lumbar. And that's the beauty of retrospective reconstructions. Again, the takeaways with retro recons are that we have to have raw data to do it, and it's always in the same plane as what we scanned. Okay, so we're just taking the axials and we're changing them to appear differently and to focus on different anatomy potentially. So that's the retrospective recon. Does anybody have questions about that? Does that kind of make sense? All right. So one of the things about being on the Zoom, Hannah and Danielle, is every part of the reason you get the points is participation. So it can't just be on mute the whole time, right? You got to ask questions and kind of give some feedback too for it to really work.
Okay.
Thank you. All right, so we'll jump into the overlapping reconstructions. This isn't as common of an occurrence as it used to be because scanners are just better. We acquire images already on the Z-axis in really thin slices, right? We're talking acquired at under 1 millimeter or maybe just 1.2 millimeters or something like that. So these are typically acquired really small anyway, so this doesn't happen as much. But what it's saying is you can do reformations. Don't get those confused with reconstructions. Reconstructions utilize raw data. Reformations utilize image data, okay? So what we do with the reformation is we take the slices we have and we stack them all together and then we slice them in a different direction, all right? And there's some things that affect that. So one of the things that helps so that you're not missing data is to do a retrospective reconstruction of what you've already scanned and do thinner or even overlapping slices. So if I do like a 3 millimeter slice here and here, that's contiguous, right? I'm not missing any data. But say I do the 3 millimeters and I have an increment of 1.5, all right? Now I've got 1.5 millimeters of overlap between the two. And that just makes sure I have all the data. Now, we don't send that reconstruction to the radiologist. We just create it and then send it over to a different portion of the machine that's gonna let me do my multi-planar reformations, like coronals and sagittals. That used to be the way we had to do it. We'd have to do a thin reconstruction or even overlapping reconstructions. Otherwise, the coronals would look really pixelated or even staggered. On older systems, that was common. That's not what we do anymore. Typically they're scanned so thin and we have near isotropic voxels anyway that we just straight out, we can just go straight over to the multiplanar reformation and just do the coronal, do the sagittal, or really any oblique, any plane we'd like to, okay? So there's that. Does that make sense for everybody? Like why they might do overlapping?
Yep.
Thanks. All right. Let me see what else there is. Yeah, when we talk about reformation, I just explained it. It's really using image data to reconstruct in a different plane. If we're just going to redo axials, we're going to use the raw data, and we're going to We're going to use raw data, and we're going to manipulate some of those parameters. Make sure you make note of what you can manipulate on a retro recon versus what you're going to change on the reformations, okay? So just kind of, I think your worksheet might walk you through some of those, but you need to be clear on that. So again, reformations are image data, reconstructions are using raw data, all right? Any questions? All right. So we will talk about the NPRs just a little bit more. You can do manual real-time NPRs or the scanner-created NPRs. The way this works in practice is if you use a GE scanner, a lot of those are set up to just spit out the reconstructions. The interface on the GE isn't quite as friendly as the Siemens and some other scanners. So it's nice. It just spits it out and goes skin to skin. The only issue with that's the scanner-created NPR. The only issue with that is sometimes it clips anatomy. Sometimes it misreads the patient, and you don't get like the entire, like if there's a ventral hernia here, you may not get that whole hernia because the scanner didn't pick up on it. And so then you have to go back and do a manual anyway. So whenever I'm scanning, I just prefer to disable that feature, and I want to do my own because I trust myself more than I trust the machine. It takes me about 15 seconds for each. It's not like it's a big time commitment. So it's quick. So the manual obviously is user does it. The scanner is the machine does it. And again, you can reconstruct in any plane. Now workstation created NPRs, I've not seen those yet, but I know they exist at larger facilities. You know, the RADs at these smaller hospitals, like a lot of our clinical rotations, they don't want to manipulate the image, right? They don't have time. They're reading from multiple modalities. They want it to come to them so that they can pull it open, read it, sign off on it, move on to the next patient because they're doing 100 a day or something crazy. Now, if you're into specialty, like if you read cardiovascular only, maybe you want the capacity on your workstation as a radiologist to be able to create different planes, right? So they would request thin images, and they would all load on their computer. And then they would manipulate it on their workstation, build a 3D model, spin it around, look at this specific artery. That's not common because they're bulky. If we do thin images all the time, we're going to fill up that PACS system incredibly quick. So we don't want to do that. But in this case, with a workstation created NPR, that might be what has to happen. All right, so let's go to three-dimensional reformations. So these are interesting. In the previous version of the text, this was a little heavier. What it is as technology's improved, they've eliminated different ways and created new ways. It's just not as much as it used to be, which is nice. So when we do helical scans, we acquire a volume of data, right? We have total volume of data across this body. There's no spaces. As long as there's no motion or anything like that, we've got this massive data set. So we can virtually take any structure in the body and we can build a 3D model of it, right? From skin all the way down to vessel, depending on what we want to look at. And we can isolate it and we can spin it and look at it from any direction. So what this section is discussing is the different methods of doing that and what they may look like. So the main two are really surface rendering or surface shaded display and then the volume rendering. Back when I started CT, surface rendering was what we did for shoulders, or for one of our orthopedic surgeons really liked that surface rendered shoulder, but it doesn't contain as much information. So let's talk about the surface shaded display. It is only going to give you the pixel values on the outside of the object you're looking at, and so there's no real depth to the data. Right? It's thin, if you will. It's kind of light. It's just the outside pixel value, and you can spin and look at the outside. The issue with that, and you've probably seen it if you've looked at the anatomage, if you go to the x-ray part, you start to try to window level to get the bone to come out. Well, you'll pull a vessel in, right? And then, or you'll pull a vessel out and some of the bone will go out. So surface rendering really depends on the threshold values you set, and that's what we're really changing on the table when we manipulate that. Is that threshold that it's talking about there. So it's hard when someone doesn't have consistent bone density. Like somebody who's osteoporotic, if you try to do a surface shaded display, half of the bone is going to be gone and the other half is going to, so you're going to have like this chunky looking model that is inaccurate. So it's just not used as much anymore. You just don't, because of those reasons. And because before those surface renderings, they were small enough that computers could operate with them. Well, now computers are so good, they can deal with massive amounts of information a lot more easily. So it's kind of gone the way of the dinosaur with that. Only uses about 10% of the data available for the surface rendering, whereas for the for the volume rendering, it's like everything is utilized. All right, let's talk about MIP and MinIP before we jump into the volume rendering. So MIPs, you can do 2D or 3D MIPs, I'm pretty sure. It says 3D techniques, but you can do, for example, you guys have probably all either seen or done a pulmonary embolism study, right? So when you do the coronal reformations, on a PE, those are always set up as a MIP. Whenever you're looking at vasculature, you're looking at a MIP. So you can do a 3D MIP that you spin, but you can also do 2D MIPs that look just like regular images, okay? So it's not only a 3D technique per se, if that makes sense. But the MIP stands for maximum intensity projection. So what it's saying is, so I'm looking straight on at somebody's chest on a coronal, and there's one pixel I'm looking at. Despite the depth of that whole volume of data, it's going to give me the brightest singular pixel right there in that chunk I'm looking at. And on the next slice, it'll do the same thing. So I'm only seeing the brightest pixels. Anything that isn't of that value, it's gone. The system gets rid of it. So effectively, what a MIP does is it highlights contrast-filled structures or bony structures. That's all you're going to see, the things with the highest Hounsfield unit values. Everything else goes away. But for vascular studies, that's a really good thing. It emphasizes stuff. So you always do a MIP coronal on a PE. You do MIPs when you do CTAs of the body in general, really. CTA, chest, abdomen, pelvis, whatever. A MinIP is the inverse. It's going to give you the lowest intensity pixel that's in that you're looking at. So that's going to be good for like air-filled structures, like the trachea and the bronchial tree. You can do that. Again, on the table, there's a setting. You can pull up the X-ray and you can turn it so where you can see the lungs and the bronchial tree. That's what it's doing. It's just reconstructing or reformatting a MIP or a MinIP for the airways, and then a MIP for the vasculature contrast-filled structures. Okay, do those two make sense? So be able to understand what those are and recognize a MIP when you see it. The best way to do that is when you're scanning PEs out of clinics. Look at the difference between a coronal chest of a regular chest, and then look at a PE's coronal. You're going to see it's going to be super bright compared. You can distinguish a MIP from the regular. All right, volume rendering. So volume rendering is going to use all the data there to display the information, okay? Let me see, yeah, each voxel along the line. So all the information along that line is contributed, is used instead of just the surface, like on the surface rendering. Hello, nice of you to join us, man.
I forgot about the Zoom. Oh, my bad.
All right,
Is that what we want?
yeah.
Oh my gosh, April, you need to get it together.
That's why I text you.
Why didn't you say Zoom?
What did you think I wanted? Oh man. All right. Yeah. So with the volume.
That was
Whoop.
So with the volume rendering, we can do a lot of manipulations with that. The volume rendering is typically like if you look at these pictures in your book, Figure 8.8, you can isolate these different structures, like the pulmonary veins, or the entire cardiac vasculature, or the heart itself. And when you window and level in that, it's going to pull different structures in and out. essentially the whole table is a volume rendering. So everything, a lot of manipulations we do there, that's what they are. And you can do those things on your scanners. Does that make sense as far as the volume rendering goes? It takes up a ton of space. It gives you a lot of options. It's also like the most common 3D reconstruction now. The most you're going to use that volume rendering is going to be CTA head and neck. If you ever work at a stroke center in
It's the most common, right?
3D reformation you're going to do is the volume rendering, and it's going to be on like CTA head and neck. You work at a stroke center, nowadays all they're doing now is they're going to order a CT head, rule out bleed, they'll do a neural consult and order a CTA head and neck right then and there. So you're going to scan from the aortic arch all the way through the circle of Willis. But then you have to do these 3D reconstructions, reformations, I guess is what they're called, 3D reformations, and spin them. All right, these are volume rendered structures that you're spinning in the 3D tab. And we'll talk about more of the things that they talk about in this chapter will apply around that same study, the CTA head and neck. So endoluminal imaging is like a virtual colonoscopy. So again, on the table, we can do the fly-through method, right? And we can look through the bowel if you want to. So that's what they do. Like they would fill the air or fill the colon with air, and then you'd scan them, and then you'd go into your 3D card on your workstation, and then you would be able to set up an endoluminal imaging where you would literally tour the vessel. So that's figure 8-9 in your text, where they're touring some of the. Actually, that's the heart. You can do it with the bowel. Any open space, and you can really get a look at what's going on. So if we wanted to look at polyps and things like that in the bowel, we could. Now this part's new. 3D modeling. 3D printing is kind of like a new trend, right? And it's spreading, so it's going to be more and more common. So CT, this is now moving into something that we get to do as technologists. So from our scans, they're so accurate and representative of the anatomy that they can now load that data in a specific format into a 3D printer, and it'll just print out, an identical copy of the heart and vasculature, or of the skull, or maybe you need a prosthetic orbit. They can print that out and put it in. So that's impressive, super impressive. For a while now, though, they have been utilizing CT scanners to build virtual models of the sinuses or something like that, so that they can go in and use that for surgical planning. But now they're bringing it into the real world and printing these things. So there's a Mako knee is what they call it. Mako's the company. And you'll scan hips, knees, and ankles. And you got to put a bar on the table so they know the exact thickness, and it gives them scale, this thick metal bar. But then what they do with that is they take the relationship of the joints along with the length of the bone and everything like that, and they build a perfect specialized prosthetic for that patient. The benefit of that is like prosthetics used to be kind of a one size fit all, maybe 4 sizes fit all. So you see the surgeon in there asking for specific, let's try 20, let's try this. And now they come in 2 days after the scan, and they've 3D printed this perfect joint for that patient. That's a huge thing in terms of improvements in medicine. So, and that's something that CT also allows us to do. All right, so let's talk. Any questions about the volume rendering or anything like that? Okay. Region of interest editing. This is important, and this is where a good CT tech kind of sets himself apart. Is 1, in your understanding of anatomy, 2, in your mastery of the equipment that you're utilizing. When we do region of interest editing, what we're trying to do is we're trying to say, I want only the vasculature, none of the bony anatomy. I'm doing a CTA, right? I have to remove the spine. So like in the C-spine, the transverse foramina, that's where the arteries pass through. But how do you distinguish contrast-filled artery from bony anatomy when they really attenuate almost the same amount of Hounsfield lines? Or they're really close to each other and they're touching. So it gets really tricky to delete the bone without also deleting the anatomy of interest. But to allay your fears a little bit, when it comes to RADs, they don't diagnose off of your 3D reconstructions. They do their diagnosis off of the axials. Everything else is just kind of secondary or tertiary confirmation. So just keep that in mind, but you still want to do it right. You want pretty pictures, what the patient sees it, what if you send it home with them, that kind of thing. All right, there's different ways to do it. Manual segmentation is where I pull the information, my raw data over, or actually I can use image data for this too. I pull the exam into what's called the 3D card. On the Siemens, there's a specific card. On others, there's a specific workstation you would utilize, because this is going to take up the PCs. You're not going to be able to scan while you're doing this. So sometimes one tech will keep scanning, another one will go start the post-process on a workstation. So I'll load the information in, and then there's various tools, depending on the vendor, that are going to allow me to begin to delete information I don't want. That's what segmentation is. And the manual part is I'm selecting as I go what stays and what goes. Stays and what goes. I'm deleting information and highlighting others. The fully augmented segmentation that's interesting. So, I'm sorry, is it fully automatic, right? Yeah, fully automated segmentation. So one of our workstations is called a Neuro DSA. DSA is digital subtraction angiography. What we do for that, when we do our CTA head and neck, we'll do a scan of the head and neck with no contrast, and then we'll do a scan with contrast right after each other so the patient can't move. We send both of those in 0.75 millimeter slices to a workstation. Then we load them, and that workstation takes the without, and then takes the with, and it lays them directly on top of each other, and then it just subtracts the bone out. It just takes all the bone out. So all you're left with is the vasculature. And so that would be a fully automatic segmentation, where the machine is able to pull everything out and you send it through. The problem with that is the machine makes errors. The patients move. You can't depend solely on the equipment to do the work for you. So you've got to do some of it. So typically what happens is there's semi-automatic segmentation. So your typical process is you send it through some type of either digital subtraction workstation, like we just talked about, or you there's different options that'll the system will do its best to remove the bone. It'll do its best to remove the vasculature, whatever you're trying to isolate. And then you go back in and you touch it up. That's what it is. That's all it's saying with semi-automatic segmentation. You're gonna have to go back up and clean up the mess. And then you do whatever you need to do and send it on. All right. What are some of the factors that degrade reformatted images? Segmentation errors. Those are pretty common. Again, we discussed that. What if I clip a portion of the carotid and then I make a 3D MIP model that I'm spinning around and it looks like there's an occlusion? Now I've created a pathology that isn't real. It's a segmentation error. Or if I say I have to do something on a PE and somehow I clipped some of that vasculature. Now it looks like they have something blocking one of their pulmonary arteries, but in reality it's a segmentation error. So we have to be careful that we're not clipping anatomy that we need. I'm trying to think of what the most common one might be. Just as a general rule, if it's better to send more information than it is less. Right? I'd rather leave a little bone in there and have all the vasculature than cut the vasculature out just to get to the bone. Right? Like cutting off your nose to spite your face, that kind of thing. I don't want to do that. I want to leave as much diagnostic information as I can. So does that make sense? Segmentation errors.
Mm-hmm.
So those are typically user-generated errors where we screw it up. Okay. Image noise. We talked about noise before. Basically, noise is just we don't have enough information to have an accurate image. Those are gonna screw up your reformations. Because remember, reformations use which kind of data?
Reformation uses image
data. Yes, reformations use image data. So if I've got a ton of noise or a really noisy image, then I'm going to have really noisy reformations. My coronals and sagittals are going to look like crap. I mean, that just makes sense, right? Artifacts, same thing. Huh? Sweet. Thank you. Love it. All right. Okay. Did we already go 40 minutes? No. Okay. All right. Cool. Interesting. So, if you got like a hip replacement, and I do a CTA, and I need to get through the iliacs, those arteries, the hip replacement is going to send a huge streak across the middle of the pelvis. When I go to do my 3D reformations and spin that, there will be no data there. The metal streaking artifact will have removed the data, and that artifact is going to adversely affect my my reformation. So motion's the same way. Anything that's going to affect my normal image is going to make it even worse when I do a reformation. Okay. All right, that's post-processing in a nutshell. Does anybody have questions about that? No?
Nope.
Thank you, Danielle.
You're welcome.
Quit sucking up.
Well, I got in trouble earlier for not talking.
Oh.
Was it Trump?
Yeah, April. And I showed up on time.
Oh, yeah, she did. All right. We're going to talk about data management. The data management component of this is minimal as far as what do you need to take away for the registry. This will not be a huge chunk of it. And in my mind, yeah, PACS and DICOM. There you go, and we're done. Close your book. Like that's the gist of it. And in practice, you definitely don't deal with this a lot. But maybe one of you want to go on to be a PACS administrator someday, or kind of oversee some of that stuff. So yeah, here in the next few years, this stuff is like with 5G and the cloud expanding. This chapter will be a new chapter. So I'll give you what I think is important here. Obviously, you got to take the worksheet test anyway. But this is just content, right? This isn't, a lot of it's not applicable, okay? One of the big things about informatics, though, and CT is, how many of you guys' facilities use the cloud? Do cloud images in bigger hospitals? Or to a cardiologist? Huh?
How would I know that?
I don't know. They ask us to do it at my facility.
I mean, I send images to other facilities.
Yeah, that's cloud. Yeah.
Oh, I didn't know that.
Yeah, and so it just, so now like I'll do that, say that same example. Stroke protocol comes over, I scan the head, they do a neural consult in the ED, I do a CTA head and neck, you know, they're positive for stroke. They're like, hey, can you cloud those images to St. Luke's in the plaza? I'm like, yeah. So I click a button, and now those images and the report are all sitting with the neurologist at the site that can take better care of that patient in an instant. That's incredible. Back in the day, we'd have to try to burn a CD. Before that, they just had to wait. Actually, before that, what they would do is just scan them again. So people were getting double and triple doses as they're moving from facility to facility. And so it's really nice. That's the benefit of these informatics, all right? Some of the factors are things that it talks about in here in introduction to informatics, right? If we talk about this, we've got hospital information systems you should know, right? That's typically Meditech or Cerner, right? Those are the big ones. Epic, is that what it's called? Epic is a big one with St. Mary's. So those are all hospital information systems. They're housing for billing information, patient information, account information, medical charts, and they integrate that. And then those systems, the HIS connects with the computed physician order entry. So most doctors now, just from their phones, they can log into their account. I need the 2-view chest X-ray on bed 320. I want it done by 6 a.m. Shortness of air, right? It grabs that, it attaches to that patient's account number on a specific visit, throws it over to PACS, throws it, opens a folder on PACS, opens an order on Meditech. Like it's this entirely interconnected system now, and now it's wired through the entire hospital and across hospital networks. So HCA and these big groups, they're all connected now. And so this is the benefit of informatics. We still have yet to have a comprehensive electronic health record, but I think like Health Level 7, is that what it's called? There are some organizations, and there's a push to creating this comprehensive, accessible, or even portable medical record. Another cool benefit is like we've got the portal now. Almost anywhere you go, say you get your labs drawn, you can log in on your phone and you can pull up your results at home. You don't have to wait on the doctor to call you. Same thing for the portals are incredible. We have a Children's Mercy with my son too. And it's just streamlines communication, and it really, one of the big benefits is it empowers patients to take control of their own care, which is really important for our healthcare system to stay afloat. So, all right. So all that informatics stuff, CT eats up space. That's the reality. It takes up a ton of space on servers. You store that's just with the image data. So it'd be cool, in my opinion, at some point to be able to store some of this raw data so we could bring it back and manipulate it if we needed to identify structures later, maybe cancer staging. Maybe we didn't see it, like I was talking about the pancreas earlier. Maybe we didn't see that pancreatic nodule 2 years ago when we scanned it, but maybe it was there. We had the raw data, we could pull it back in, do the retrospective reconstructions, thinner, kind of a sharper algorithm, and then see it, and maybe that'll help them understand the progress of the specific pathology. But I don't know. Right now they can't. CT takes up a ton of space. So we have hard copy versus electronic archiving. We used to do a lot of CDs. We would do the magnetic tape. We would try to save the images however we could. That's really a thing of the past. I don't think there's any facility that like once a week pops a CD into the CT scanner and burns off all that data and archives it. We used to have to do that. I don't think there's anybody that does it anymore because you can get a terabyte or whatever for like $200 or something stupid. Massive amounts of data storage now is relatively cheap. So it's all electronic archiving. We're just sending it to PACS. They sit on those RAIDs. And
RAIDs, yeah.
All right, PACS fundamentals. You guys know what PACS is. I'm not going to spend a lot of time on it. Picture archiving communication system. It's where we put all our images. Okay. Networking. So whenever you link together more than one computer, now we have a network. You guys should be familiar with networking because it's kind of the language that we speak, like in this generation, right? Everybody knows the internet's not new. If you work at any facility, most of those computers can access a network. The whole college is on a network. Every hospital is on a network. That's just saying that this is a group of computers that communicate according to specific rules and privileges with access, right? Like that's the deal. Now, the book talks about a few different types of configurations of networks. Local areas of LAN.
Peer-to-peer?
No. Well, that's a type too. So large networks over a large geographic space. A LAN, I think, needs they need to be wired together. So like at the college, there's these plugins in every room, and those are hardwired networks. A WAN, on the other hand, doesn't necessarily have to be wired as far as I understand it. Let me look. Yeah, they can be wired, or they can go through radio waves, whatever. But one's local, just at the hospital. One's going to be this massive network, and that's the WAN. And then there's the different geometric topologies. You got to know those. It's probably going to be on your test. Just make a note, highlight the box. You may see that again on your registry.
What, huh?
It may be on your test.
What is?
These topologies, the different configurations of networks, how they might be. Did we go to VPN yet? I'll go ahead and talk about it. One of the things too is a lot of the radiologists, like my radiologists, when they go home, they take call till 11 p.m. They get off at 4 or 5. But when they're on call for CT only and maybe an ultrasound. They have reading rooms at home, so they have the high definition monitors. They can log into the private network, so the VPN access to give them a secure access to PACS, Meditech, basically their office computer in their house. So that's another benefit of the networking setup. Obviously, the more hands we get in the pot, the more potential we have for security risk, and that's kind of the flip side of this stuff. But broad classifications are peer-to-peer or client-server. Peer-to-peer is like, I don't know that I've ever seen a peer-to-peer network. It's where every computer really kind of talks to every other computer. in a back and forth. Like if I had a computer in this room and a computer in my office and one in there, we could just pass information around just directly to them. You could set up peer-to-peers at home. Those are pretty easy. And then you can pass information between PCs at home, and that's nice. But in a place like a hospital, peer-to-peer networks could get busy. You have access issues and too much stuff going on. So they typically have a client-server network where the server holds all the information. The clients have access and they can touch it. And that's the most common model. So the servers at hospitals are usually like in these big rooms in the basement. And they're just a ton of computers in these big cabinets. And IT just plugs cords in and manages it, makes sure it's working. And then from our perspective, we log in on any PC on the network. That's where the client, boom, we have our access with our specific set of privileges, and we can do what we need to do. Okay, and they can track almost anything you do, by the way. So just in a network like that. All right. So we had the advent of digital imaging, and then people were like, okay, so we've got all these different types of images. What format do we want to use that is going to allow that to be used anywhere? We needed a universal standard of digital imaging, and that's DICOM. Now, there's been some updates to DICOM over time. Health Level 7 had a lot to do with creating some of these digital imaging standards. But just know, DICOM is the universal format for imaging. All right, so yeah, you guys should know that. All right, we talked about workstation monitors, and that was on output devices, I think, earlier. So CRTs, we don't use CRTs. Cathode ray tubes are a thing of the past. They don't exist except at your grandma's house or something like that, all right? It may not work. Yo, it's dark. So typically we use the liquid crystal displays or any other high resolution type of monitor. All right, data storage, got to keep it somewhere. Again, I said CT takes up a lot of space. The book talks about these 256 slide scanners. That's a lot more information, right? 128 was a lot of information. So these systems definitely don't store raw data, not for long. Typically they auto dump in about a week or two. Okay, anything that's been sent, these systems are set up to just dump what's already been sent over. And then we typically send whatever to PACS, and that's where it's stored. Let me see. That is going to be like a nearline storage. So you can have online, offline, nearline, all these different terms. You need to know them. Offline is like if I burn a disk. Nearline is like near accessible, and then I think, does it say online in there too?
I don't have my book.
Yeah, online. Yeah, and online obviously is online. So all right, not random. So I told you RAID wrong. I called it a random array. It's a redundant array of inexpensive disks. So RAID is it's just a bunch of hard drives stacked together, which is a redundant array of inexpensive disks. All right, redundancy meaning that you have the same thing stored in multiple locations. So if one of my disks goes bad, then I still have a copy of it on the other 3 or 4, however many I have in my array. So it's a redundant array to protect the data. Yeah, we really don't have to go too deep into it. It just says that RAID 5 is the design most frequently used for PACS archives.
Okay.
All right, optical storage, those are the things we burn, right? CDs, Blu-rays, DVDs, that's an optical storage. Magnetic tape shouldn't even be in here anymore, but you used to be able to record stuff on magnetic tape. It's not a thing any longer. And then image distribution, we utilize PACS now, right? In a server-client relationship, we've got all these modalities that are bombarding PACS, this massive server system with data, with information, with image data. And so we send it all in one place, and then anywhere we need to send it, whether it be on the cloud to like St. Louis or City Hospital or to the cardiologist specifically, boom, we can send it from PACS and it's distributed. So, and then that's where it talks about VPNs, the virtual private networks that the radiologists use to, they can access to. So that's the gist, man. That's, in a nutshell, this stuff is simple. There shouldn't be a lot to it. Very straightforward worksheets, hopefully. I need to look something up for you still. Yeah, just simple information this week. It'll get a little more heavy when we go back into patient care. When we start talking about contrast and stuff like that. So what to expect here, we'll finish up the first 8 weeks. When that's done, the whole format of the class is gonna change gears for you. Honestly, it should get a little simpler because we'll do a week of anatomy followed by a week of procedures in CT, like the how-to scan and discussions of protocols. Okay. So if you do have a chance to get around a scanner as we move into that area, it's really going to be beneficial to be able to see what we're talking about. So, all right, any questions? All right, cool. Thank you guys for your time.
Thank you.
Yeah.
You're welcome.
Bye.
Bye.
See ya.